Ectopic pregnancy is pregnancy that's implanted outside the uterine cavity. It is increasingly common in the UK and occurs in every 1 to 100 pregnancies. The implantation sites of ectopic pregnancy, the commonest site is the fallopian tube, so you have 95% implantation in the fallopian tube, and less common sites include the cervix, the ovary, and the abdominal cavity. What are the risk factors of ectopic pregnancy? Ectopic pregnancy is caused by conditions that damage the uterine tubes or their ciliary lining, and anything that distorts the cavity itself or predisposes to abnormal implantation, thus hindering the passage of fertilized egg towards the uterine cavity. Other risk factors include previous tubal surgery such as sterilization or reversal of sterilization, if you've had a previous ectopic pregnancy, any history of pelvic inflammatory disease, if you've had IVF, if you have an intrauterine contraceptive device in your body known as the copper coil, or if you're taking the mini pill or progestogen on a pill. If you've had previous pelvic surgery such as appendicitis, if you've had endometriosis, and if you have increasing maternal age. What are the clinical features of ectopic pregnancy? The classic presentation is collapse with abdominal pain, or you might have unilateral pain in the lower iliac fossa. Bear in mind that because you're pregnant, you would not have had any periods known as amenorrhea, or you'd have had an abnormal last menstrual period that's lasting for 4 to 10 weeks. Expect lower abdominal pain, which can range from a vague discomfort to generalized pain, which happens in 90% of cases and can be referred to the shoulder tip, and this is because the blood is irritating the diaphragm. You might also see scanty but dark vaginal bleeding. Other causes to consider apart from ectopic pregnancy might be a threatened or incomplete abortion, appendicitis, endometriosis, and degenerating fibroids. If your ectopic pregnancy presentation is acute, expect to have sharp tearing pelvic pain, which is referred to the shoulder tip and associated with fainting. If you have any of these features, you need to see a doctor and they will do an examination, including investigations such as a full blood count, a pregnancy test to confirm pregnancy. You would have a transvaginal ultrasound, which visualizes any ectopic or intrauterine pregnancies. You will see the appearance of an empty uterus on scan, or the presence of a positive pregnancy test should raise strong suspicion of ectopic pregnancy. The scan might also show free fluid in the pelvis if there's been bleeding from the ectopic pregnancy. With this serum beta HCG test, it's done if the diagnosis is in doubt, and if levels are greater than 1,000, the intrauterine pregnancy should be seen on the ultrasound. If levels are less than 1,000, repeat again in 48 hours. In normal pregnancy, you would expect the beta HCG to double every 48 hours, but in abnormal pregnancies, intrauterine or ectopic pregnancies, they have impaired beta HCG production and there is a prolonged doubling time. A more invasive investigation would be a laparoscopy, which allows direct visualization of the ectopic pregnancy, but may fail if the pregnancy is early and the gestation sac is small. Another investigation is called coldocentesis, and this is when a needle is advanced into the posterior vaginal fornix. When 10 ml of non-clotting blood is aspirated, the test is positive. So how do you manage ectopic pregnancy? The aim is to minimize the risk of future pregnancies being ectopic and to preserve fertility. Surgical options include a salpingotomy. The ectopic pregnancy is removed from the tube through incision, which is left open to heal or suture closed, and the products of conception are removed by forceps or by suction. A salpingectomy is when the affected tube is removed by laparotomy. This is done in ruptured ectopics as the tubal anatomy might have been damaged. Medical options. This is done if diagnosed on ruptured ectopic pregnancy is less than 4 centimeters. Medications like methotrexate inhibits the DNA synthesis and cell multiplication in the trophoblast, which is the placenta. The methotrexate is either given intramuscularly or by direct injection into the fallopian tube, either at laparoscopy or under ultrasound guidance. In terms of follow-up, patients treated by conservative surgeries such as salpingotomy or methotrexate must have serial beta HCG levels measured weekly until the levels are undetectable. This ensures removal of all trophoblastic tissue. Complications of ectopic pregnancy can include a rupture where you have massive bleeding called a hemorrhage, or infertility. You might have complications of pelvic surgery such as post-operative bleeding, and there is a 10% risk of subsequent ectopic pregnancies.